Hello, good evening, and here's part 2 of the colon cancer talk for tonight. Again, done in video recording because the live stream on Facebook is unavailable. So we'll post this later when it comes back up. So, colorectal cancer is responsible for 137,000 diagnoses in the United States each year. And of those, about 50,000 people die from colorectal cancer every year. And despite these numbers, this is one of the most preventable kinds of cancer. They say that at least 70% of them is a preventable thing. And you might say, well, how can we prevent colon cancer? Well, not only is it important to eat a diet that's varied and rich in fruits and vegetables, whole foods especially, but also to get those early important screens. And the screens for colorectal cancer are can be very non-invasive, such as getting a stool occult blood every year. So basically that means taking a little stool sample and putting it on a card and giving it back to your doctor's office so they can check it. To a little bit more invasive procedures such as a colonoscopy, starting for most people around age 50 and usually about every 10 years thereafter. There's a couple other ways in which colorectal cancer can be screened for, and basically it's important to not just wait for symptoms of colorectal cancer, but to follow the guidelines for your age group, because many times colorectal cancer can have some symptoms, for example, bleeding from the rectum, especially dark blood, abdominal pain, iron deficiency anemia, where there's really no reason to be iron deficient. There's a difference between, like, say, a young woman that's having a lot of heavy periods. There's a reason that we can see right away for the iron deficiency. But if somebody is, for example, a woman that's gone through menopause, or a gentleman, there's usually no real reason for them to have iron deficiency, except for sometimes slow blood losses through the colon. Or a change in bowel habits, especially if the stool is a regular size and then all of a sudden becomes narrowed over time. So those are some of the symptoms of colorectal cancer, but a lot of times it has no symptoms whatsoever. As a matter of fact, 1 in 5 of the people that are diagnosed already have metastatic cancer. Basically, it's left the colon and it's gone somewhere else. Colon cancer tends to go to the lymph nodes that are in that area, the liver, the lungs, and the peritoneum, so basically the lining of the inner abdominal cavity, so basically belly area. And so because of that, that's one of the reasons why these colorectal cancer screenings are so very important. And who should be screened? Well, generally speaking, across the board, adults who are over the age of 50 should be screened in one form or another. And occasionally, people have some risk factors that cause them to be recommended to get screened even sooner than that. For example, if a person has a first-degree family member, that means parent, brother, sister, child, who's had colorectal cancer or colon polyps prior to age 60, then they recommend that the person get screened either at age 40 or 10 years prior to the first diagnosis. So, for example, I've had patients that their mother might have been diagnosed with colon cancer at age 35, and so their first colon cancer screening should be at age 25. If the brother had a colon cancer diagnosis at age 55, then it should either be at age 40 or 45. I guess by that criteria it would be at age 40. So we kind of go whichever one is a little bit earlier, just to be on the safe side. There's one other condition. If you've had 2 relatives diagnosed at any age, and that's also another reason to start the colorectal cancer screening at age 40 rather than at age 50. There's a few other conditions that are pretty rare. Lynch syndrome, otherwise known as hereditary hereditary non-polyposis colon cancer. Sorry, it's a mouthful. And basically, those folks tend to get colorectal cancer screenings at a much, much earlier age, and that are done much more frequently, like every year or every other year. And then there's another group of people with a rare genetic condition called familial adenomatous polyps, or FAP for short. And those folks, they get also intense colorectal cancer screenings because about 100% of the folks with that condition develop some sort of colon cancer before age 50. Another group is inflammatory bowel diseases, Crohn's disease, ulcerative colitis, and generally speaking, it takes about 10 years of intense disease activity to really put somebody at very high risk for colon cancer. And those things are things that are definitely something to be keeping an eye out for, because for the first time in a while, we've noticed that the younger generation, adults under age 30, are starting to get a higher risk of colorectal cancer. And whether it's because we're getting more inflammatory bowel diseases or for some other environmental factor that's yet to be completely sussed out, that's a trend that is keeping a lot of folks on their toes, so to say. And so if you do start to get any of those symptoms of colorectal cancer, please do talk to a physician, or if you happen to meet those criteria that was just outlined, those would be other reasons to talk to somebody as well. So a little bit more about the types of colorectal cancer screening that are available. So I mentioned colonoscopy a couple times. That is the preferred choice of the GI doctors in America. We have a disagreement with some of the GI doctors over in European countries and Canada because there the fecal occult blood tends to be the preferred choice, whether that's because it's less invasive or for other reasons. There's a little bit of a gap in there. And if you are doing the colorectal cancer screening via a colonoscopy, there are a few risks involved with that. It's very rare that people have any real complications other than when you drink the kind of stuff that cleans everything out and you get nausea and diarrhea and stuff. That's kind of expected because that's kind of what the clean out medications do for you. But when you're having the colon cancer screening, about 1 in 1,000 might have a problem with that, like too much gas or a weakened colon that can perforate as well. And so the specialists are prepared in case of any emergencies such as that, and most times things can be taken care of fairly easily or in a timely fashion. So the benefit of having a colonoscopy is that if a colon polyp is starting, and so the way that these things start is, let's say that this is your colon. Obviously it's not really a colon, and then let's say that this is representative of a polyp. Well, basically, colon cancers start as these little tiny polyps that are basically growing out from the inside of the colon. And the nice thing about a colonoscopy is when you see that, they can go in there, get a little biopsy of it, they can basically clip it out, and basically make it so that that polyp is gone away, and then basically you've just cured colon cancer before it even had a chance to begin. There are two types of those polyps. One is called hyperplastic, which basically means a growth that kind of came down in there. And then the other is an adenomatous polyp. Now the adenomatous polyps, those ones tend to develop into something sometimes. It's not a for sure that an adenomatous polyp would definitely cause colon cancer, but if it does, it tends to do it over the course of about 10 years, which is why when people get a colonoscopy, they're usually given a clean bill of health, said come back in 10 years, good to go. Or if they have certain polyps on, when they take it out and look at it under the microscope, that they say come back in 5 years. And if it's a particularly troublesome polyp, they might say come back in 1 year, 2 years, 3 years, depending on what the individual situation is, depending on what the medical history is as well. If someone has a family history of colon cancer, they usually end up getting colonoscopies every 5 years rather than every 10 years. So just a few things to keep in mind when you're discussing these things with your private family physician or a GI doctor. There's a few other newer kind of tests that are in town, and basically the C-scope, as mentioned, is preferred because you can do stuff while you're in there. You can biopsy, you can clip the thing out, and basically make it so that the precursors to the colon cancer, those little polyps, just go away. There's another thing called a CT colonoscopy, and the CT colonography, basically, you're still doing that clean out. You're still drinking the stuff that washes everything through, but it's a little bit less invasive. They're able to see the entire lower GI tract through that and get a sense for whether there's any masses growing or anything in there. The downside of that is that the body is exposed to a little bit of radiation, and the other downside is that if they happen to see evidence of a little polyp or even, let's say, maybe a bigger mass, which I'll just illustrate here. Let's say that they see some blockages in there. Well, they're still going to want to get a biopsy in order to make for sure or to prove that it was colon cancer. So, and also to help with the staging and the diagnosis and all that. So the person goes through all that clean out and bowel prep to get a CT scan. If they find something, then they're still going to go get a colonoscopy after that as well. And same thing with the barium enema. That's one where you drink a barium solution. Barium enema. They basically put their barium solution in the other end, and basically it's, again, the solution goes through the entire colon, and then they're able to take some pictures and tell. So barium enema, that screening is good for about 5 years. CT colonography, I believe, is about 5 years as well. And there's another one that I skipped in there that's a sigmoidoscopy. And that is where, instead of doing the entire colon, they just look at half the colon. And that's okay for a lot of folks because a lot of colon cancers happen just on one side of the colon as well. But the downside of that is you're only looking at half of the colon. So you still get some of the same risks as a colonoscopy, but just not as much visualization. The other benefit of the sigmoidoscopy is that they don't necessarily use as much sedation for it. And so for some people that could be a benefit, but also a risk. So sometimes they'll use that sigmoidoscopy in combination with a fecal occult blood test. So that same, just to check to see if the stool has got some blood in it or not, can be done for the colon cancer screening for that. So there's also a newer test as well. So in addition to the fecal occult blood test, which should be done every year if it's done, and the reason that it's done every year is because those little polyps that are growing in there, they oftentimes have a very delicate blood supply. And as stool is kind of coming through and scraping by that polyp, well, that polyp might bleed a little bit or it might not. And so essentially that's why they do 3 tests once every year in order to see is there anything going on in that area or not. And of course, if there is something going on, then they usually follow up with a colonoscopy to find out exactly what is happening. So the new test is called a DNA test, and so that is basically a more expensive test than the fecal occult blood test, and not every clinic offers it. So another thing to talk with your personal physician about. And so that wraps up the section on screening for colonoscopy. And see you again in a minute.